right, good morning, everyone. Thank you for coming today. Also, our folks attending online, welcome. It's good to have you here. I'm Jeff Williams. I'm the contract manager for this research study. And before we get going, I do need to make a quick housekeeping announcement for those of you in the room. In the event that we have a fire alarm or another emergency, a zombie attack, whatever, we have to exit the building, and so please make note of the emergency exits to the side and to the rear. Please exit down the stairway to the lobby, don't take the elevator, and head out the building and across to Cesar Chavez Park where we meet, and once we get the all clear, we can return to the building. Okay, so that takes care of the housekeeping. So today's seminar is on contract 11324, which is titled Benefits of High Efficiency Filtration to Children with Asthma. And I'd like to start by mentioning that this was a very large and a very complex study. It had many moving parts, and I'd just like to acknowledge Debbie and her staff, in particular Rebecca Moran, Dr. Bennett's study manager. They really just did an excellent job of dealing with all of the technical issues, the logistical issues that came up through the study, and I think really have given us a very, very nice final product. So with that, I would like to provide a little bit of background about the study and why we funded the study. So we've long known that PM and ozone are able to cause adverse respiratory health effects, and particularly in sensitive groups such as children and the elderly and those with respiratory illnesses such as COPD and asthma. Also, elevated PM and ozone are associated with elevations in asthma symptoms. In California, we still have high levels of outdoor PM and ozone in many areas, and so this really underscores the importance of reducing our indoor exposure to those pollutants that are outdoor in origin. And now there have been several previous studies examining asthmatics in indoor environments, but many of those studies were lacking for a few reasons. One, they had either a small number of participants. In some of the interventions, they did not use high-efficiency filtration, or in many cases didn't even document the pollutant reduction, pollutant reductions. And many of the studies did not have very long interventions, and so they may have only gone for a couple of weeks or a couple of months. And this study really sought to address some of those data gaps. Now, ARB intends to use the results of this study in a few ways. First, in terms of indoor air quality, this helps us make recommendations on how to improve indoor air quality in homes. With respect to building codes, the findings from this study were very useful in us making recommendations on using or including high-efficiency filtration in newly constructed homes. And then with respect to health, we believe that there are potential health benefits and cost savings for using filtration as an asthma intervention tool in California. And finally, in addition to asthma, just improving indoor air quality in general is going to have respiratory and cardiovascular benefits. All right, so with that, I'd like to introduce today's speaker. Dr. Debbie Bennett is a professor at the Department of Public Health Sciences at UC Davis. She received her PhD in mechanical engineering from UC Berkeley in 1999, and her research focus is the fate of transport and exposure to particulate matter and compounds in multi-scale applications. Her other research interests include looking at exposures in autism, examining or looking at consumer products, flame retardants, perfluorinated compounds, and other hazardous pollutants. And with that, I'd like to turn it over to Dr. Bennett. All right. Here we go, slideshow, and from beginning. There we go. Thank you.
Thank you, Jeff, for that kind introduction. I'm going to be talking about the impact of high-efficiency air filtration on indoor particulate levels, and we called this the AIR study. I'll go over the acronym here in a minute. And I wanted to acknowledge my other investigators, the other faculty on the project were Mark Schenker, he's the epidemiologist, Nick Kenyon, he's the asthma expert, Dan Tincrati, he's the statistician, and then the other staff and members of the team. Rebecca Moran, that Jeff so kindly acknowledged her hard work over the project, was the project manager. Katya helped throughout the project and did a lot with the data cleaning and some of the basic summary statistics. Paula Krakowiak is a postdoc that did most of the statistical analysis at the end. Mei Wu was involved at the beginning of the study and really helped a lot with getting all of the materials together. And then Bill Fisk is at Lawrence Berkeley National Laboratory, and he is an indoor air specialist. So this was the air study, asthma and indoor air, reducing exposures, and the goal of the study was to conduct a randomized, placebo, self-controlled crossover trial to evaluate the effectiveness of high-efficiency filtration in reducing indoor exposures and asthma symptoms. The study had 3 different objectives. First, in homes of children with asthma, we wanted to determine the extent to which using high-efficiency central filtration and high-efficiency portable air cleaners reduced indoor air concentrations, both of multiple size fractions, PM 0.2, which was used as a proxy for ultrafines, PM 2.5, and PM 10, and the resulting personal exposures, and the extent to which filtration also reduced the indoor concentrations of ozone. Second, we wanted to determine what the impact of these same interventions was at reducing asthma symptoms, and we measured a number of different health outcomes. Finally, in homes of children with asthma, we wanted to measure indoor and outdoor concentrations that were existing. So, what are the methods of the study? First, the study design. The goal of the study was to enroll 200 asthmatic children with doctor-diagnosed asthma, and the way we evaluated was that they must have symptoms at least 2 times per week for several weeks in a row during the last 6 months. The age range was 6 to 12, and the study was conducted in 2 areas with high outdoor air pollution, Riverside and Fresno, California. The way we recruited individuals into the study was by handing out flyers through the school systems, and then they called us in response to the flyer if they were interested in the study. In terms of the interventions, we had 2 different interventions. We either had the standalone air cleaners or we did the filtration through the central system. On the standalone cleaners, we also included filters that reduced the ozone levels. This was a 2-year study with 1 year in true filtration and 1 year in sham filtration. In other words, the air cleaner was there and they didn't know that it wasn't doing anything. And that's so that we could compare the symptoms with the true and the sham, and also compare the air quality between the true and the sham. Participants were randomized to determine if they began with intervention or the true intervention or with sham. And we recorded the usage of the standalone air cleaner or how often the HVAC system ran in order to be able to reimburse the participant for their electricity usage. And we asked participants to minimize the window usage in their home, because when you have open windows, you can have particles coming in from the outdoors, and so it would reduce the effectiveness of the intervention. So we had 4 study groups: air cleaner homes and central filtration homes, with 1 group starting with true and 1 group starting with sham in each one. The ARB was very concerned that we provided some true filtration within the first year to everyone, and so you can see that if you began with true filtration, you had a year of true followed by a year of sham, whereas if you started with sham, you had 6 months of sham, a year of true, and 6 months of sham. You can see that with the red and the green dots. If you look at the study design in the 2 years after you received the intervention, approximately 75% of the first year would be under true filtration and 75% of the second year would be under sham. There was some concern about this design because the association with filter type and follow-up lowers the precision of the estimated true sham contrast, and could lead to confounding if there were temporal effects with kids maturing or regression to the mean where their asthma is basically improving over time. We also did an alternative analysis where we looked only at the 2 matched periods where there was true and sham, the first 6 months of the study and the months 13 through 18. So this period versus that period, because then there was no confounding with time. So this is a flyer that we handed out to our study participants because it was kind of a lot for these participants. It was a 2-year study. It was difficult to explain, and I think it does a good job for introducing all of you to the study. In the top box, you can see what happened right when they enrolled. So they had an initial air quality and an initial symptoms. So that happened in the first, at the enrollment period. And then you can see in the box below, at 3 months, we interacted with them by phone. So we called and did a symptom recall over the phone with them. They also mailed some materials back and forth with us, specifically the mini Packwell, which I'll talk about later, but was a child-reported way of recording symptoms. Then at 6 months, we mailed them a symptom diary to start filling out. We came, we started air sampling, we did the asthma questionnaire, they did some lung function tests, we measured and we came back and then removed the equipment from their home. This pattern repeated itself in 9 and 12 months, 15 and 8 months, and finally with the big star when they were finally done with the study at 21 and 24 months. This is our standalone intervention. One was placed in the child's bedroom and one in the main living room. The bedroom ran 175 CFM through it, was the optimal airflow rate that we asked them to use. We asked them to do 300 CFM in the main living area. Obviously, if somebody was unhappy with this flow rate, they were allowed to change it, but this was the desired flow rate. One of the things that's important now, the big kind of driver between air cleaners right now is how quiet they are. So that's kind of where the technology and improvements are going. And so this was a new, quieter model that IQ Air made for this study with their newer motor. We asked the children to shut their bedroom door because since they did have an air cleaner in their bedroom, that would really, really get the levels low while they were sleeping. Obviously, we just asked them to do that at night. And for the sham period, we had a bypass system. So there were basically some other vents that the air came in through that bypassed the filter and then blew the air out the top. On the central system filtration, it was a filter installed over the intake, where if you do it over the intake, you can increase the cross-sectional area of it. It was a true MERV 16 filter. We installed smart thermostats into their home that were programmed to run between 15 and 20 minutes of every hour. There was a higher flow rate through a typical HVAC system, so even though the air cleaners are running 24 hours a day, the thought was we would run approximately the same amount of air through the H system if we did it around 15 to 20 minutes per day. And in the end, we ended up installing this in all of the homes that were able to take the upgrade. We also installed allergy impermeable covers for the entire time on the mattress and pillows because they had been shown to be effective in previous study. And we wanted to limit any exposures that couldn't be impacted by the air cleaning. Okay, so concentration monitoring. As I mentioned on the overview, samples were collected at pre-intervention and at 6 and 12 months of both the intervention and the control period. And by having 2 collected during true and 2 during sham, we were able to compare the intervention within the same season between true and sham. We collected PM.2, 0.2 to 2.5, and 2.5 to 10 on a cascade impactor, so those were considered as separate size fractions. And then we also did PM 2.5 using a Harvard PEM sampler. We did sampling over a 1-week period, so they're integrated concentrations over a 1 week. We put the indoor sampler in the main living area, and we collected outdoor samples wherever possible. Sometimes there wouldn't be any outdoor power, or there was no place to put it or something like that. But whenever it was possible, we collected one. We did ozone sampling indoors from May to indoors and outdoors in May through October on a portion of the population using passive Ogawa badges. So here you can see our cascade impactor and our PEM sampler inside of our pump box. The pump box that you see on the left is one of the ones set up for indoor sampling, so each sampler had its own intake. The other exposure measures that we collected were some information that we collected daily through the symptom diary, and basically we wanted to collect information about activities that might influence indoor air levels. So we wanted to not ask too many things because we wanted to minimize participant burden, but we asked about whether or not the windows were open for more than 2 hours on a given day, any potential combustion sources like cooking and smoking, and each night if the child shut their bedroom door. Primary health outcome was the number of days of symptoms over a 2-week period. We did a 2-week recall with the parent, and we asked about, the 3 questions were days with wheezing, tightness in chest, or cough because of asthma, number of days where the child had to slow down or stop their play or activity because of asthma, and number of nights that the child woke up because of asthma. And so basically, the typical way to interpret these 3 questions is to take the question that has the largest number of yes responses. And so that was how we determined the days with symptoms. The recall diary also had other 2-week events, such as rescue inhaler use, missed school, missed work for the parent if they worked, and also significant events over a 3-month period, so unplanned clinic visits, emergency room and hospital stays, and also steroid use. We asked about colds and allergies and medication use. As a covariate medication use, we both asked the rescue and the controller medicine. And we asked a bit about the home environment, things such as pets and allergies to pets were also included as information. The child completed a mini pediatric quality of life, the mini Pacwell, every 3 months as well, and that had 3 different domains: asthma symptoms, emotional function, and activity limitation. When we were there, we also conducted quantitative measures, spirometry, and exhaled NO using a NIOX monitor every 6 months. Okay, results. So enrollment, baseline characteristics, and intervention. 404 people called in and were assessed for eligibility. We had a screening questionnaire. We tracked everyone between calling and enrollment. People were randomized after they initially agreed to the study because we needed to know whether or not they were true or sham prior to consent, since we had to bring the appropriate filters to the home. Like I said, people could either have a central system filtration or standalone air cleaners. We assessed the first 147 homes for central system eligibility. Some people didn't have a central system. There were problems with the central system. It either wasn't working. Oh, hang on, my circles are messed up. There we go. It wasn't working well in the top 2. The other big reason people couldn't have the central system is that we couldn't install the filter for some reason. So if there were, as you saw in the picture, it fit over the intake valve. So if there wasn't adequate room, if there was a problem with the condition of the wallboard, if it wasn't flat, it couldn't be installed. So that occurred in 20% of the homes. All in all, we were able to install the filters in 32% of the homes that we inspected. We had 47 eligible homes, 43 of which had the systems installed, so approximately 25% of the enrolled population. And of these, 13 subsequently either switched to air cleaners or dropped out of the study. So it was definitely the smaller of the study arm. The study enrollment was 191 participants from 172 households. There was 19 homes where we enrolled 2 asthmatic siblings. We only enrolled asthmatic siblings if they both met the criteria and if they could also both benefit from the filtration. So if it was an HVAC or a central system home, both kids would get the filtration, or if it was an air cleaner home, we only enrolled the two siblings if they shared a bedroom, and thus the air cleaner that was in the bedroom would benefit both of them. 129 of our households had the high-efficiency standalone air cleaners, where, like I said, 43 households had filtration through the central system installed. 78% of the 191 participants completed the study, so 149 completed. These 149 came from 136 households. The completion rate was slightly higher among homes that had standalone air cleaners. And even though, roughly 80% completed the study, 97% completed at least one during study instrument, basically the first 3-month questionnaire, and 93% of the households completed at least one air cleaning thing. And so we were able to utilize anyone that provided some data. So, how about our demographics of the participants? 2/3 of our participants were in Fresno, 1/3 were in Riverside. We required that kids had experienced asthma symptoms in order to be enrolled in the study. And so this influences participant demographics to some extent because, when parents have the means and the ability to try and limit the asthma symptoms that their children experience, they work as hard as they can to do that. And so oftentimes the children that do have sort of uncontrolled asthma tend to be from lower SES groups. So we had 50% of our participants were Hispanic, 27% were white, then 11% Black or African American, and then 12% Asian, mixed, or other. We had 23% with less than $23,000 household income. On the other side, we also had quite a few, 34% with greater than $70,000 household income. We had a range of education levels. I mean, you do also see that typical of people that want to enroll in the study, you do have a lot of well-educated people that support science, and so we did have a lot of people with quite a bit of education as well, so sort of a range. Most of our homes were single-family homes. 60% were owned, with the remainder being rented. Approximately 40% were built before 1977. We mentioned that year because that's when homes tended to become a little bit tighter and more energy efficient. 35% with a block, less than 2 blocks, I guess I should say, from a major road. More people had gas cooking. 78% had central cooling. 5% had swamp coolers. And there was very little use of fireplaces. So this is the results on the air filtration system use. I should mention that we were recording this for 2 reasons. One, so that we could properly reimburse them for their electricity payments, and also so we would know how much they were running their air cleaner so that we could understand how that influenced our results. We recorded the usage. As I said, we were at the home every 6 months and then did a 1-week sampling period. So we looked at the usage at the beginning and the end of that week, so we were able to look at the usage during that week specifically when we were doing the air cleaning, as well as during the 6 months, the period sort of in between when we came. The air cleaner just allowed for the one-time measurement. The central system had a pressure sensor on it, and so we could see how often they were running it, and we recorded the 3 months prior to the home visits. So you can see that usage was better during the 1 week while we were sampling than over the longer time period, because sometimes things would get turned off inadvertently, and we would turn them back on when we got there. But the blue that you see on the bottom of each one is the home utilizing the system for at least 90% of the flow rate and time that we were asking them to do, and so compliance was fairly good overall. There were some difficulties with the central system, primarily related to the thermostats, because we needed to install smart thermostats in these homes that could run on a clean air cycle, forcing it to run for 15 or 20 minutes. Most of the thermostat technologies work really well when there's in newer homes because they have power directly supplied to the thermostat location, but in the older homes where you don't actually have a power supply, it becomes a little bit, your choices of thermostats are more limited in those situations. And so we realized most of our homes required, didn't have power to their thermostats, especially the older ones. And so we had some problems with EMF shielding that locked the systems on. So we had some people that sort of got stuck with their air conditioner on in the middle of the summer, and that was not perfect. Also, when it was difficult to figure out the electricity use of people's fans because everybody's fan in their HVAC system is different. So we never really had any complaints with our electricity reimbursements for people with the standalone air cleaners, but we did have a lot of complaints about the amount that we were reimbursing for the electricity for the users of the central system because they felt that their electricity bills were being increased more than we were reimbursing them for. Also, because when you're in a study and you're doing something with the HVAC system, if you have any breakage just due to normal wear and tear, the participants sort of think that that's your fault. And so, it is true we were having them run the fan longer, so when the things were related to the additional wear and tear we were causing, we tended to repair them. And depending on what else broke in the system, it was sort of a case-by-case basis. Okay, so the results. First, we're going to go over the indoor air quality results. This first slide I just show because it shows how many samples we collected. We had, nearly 700 indoor air samples collected over the course of the study. I note that we had duplicates and blanks. We had some initial problems early on with the O-ring that was being utilized with the impactors, and so we had some problems with those, and so a number of our pre-intervention samples were thrown out. But once we got that straightened out, our blanks were good and our duplicates were good as well and met our quality desires. So here is the summary of the indoor concentrations. Here I have circled the PM 2.5 true and sham values, and you can see we had much lower levels with the true than the sham. Likewise for PM 0.2. Here I show the comparison for the PM 0.2 to 2.5 size fraction. I show this in our comparison with the pre because we had more complete data for the pre-intervention period beforehand, and you can see that we actually had higher levels during the pre-intervention than during the sham period. Here is our outdoor concentrations. I show you the PM 2.5 mean concentrations for both Fresno on the top line and Riverside on the second line, and as you're probably all aware, there is more outdoor air pollution in the Riverside area than in the Fresno area. Here's the indoor-outdoor concentration summary statistics, and I just realized it. I was going to reduce it a little bit, and I did, and I forgot to mark that. Anyway, sorry. PM 2.5, we had the sham and the true. You can see that we had considerable reductions, and the 0.36 with the true is really quite a low indoor-outdoor ratio. I also showed the 90th percentile with our true filtration on PM 2.5. Our 90th percentile was 0.82. So even our highest indoor-outdoor ratios were still quite low. And here's for the 0.2. And again, even at the 90th percentile, our indoor-outdoor ratio is at 0.98. So those are low values. Here I have some distributions of the indoor concentrations with and without standalone filtration. So with filtration, all of the slides are color matched. So the PM 0.2 size fraction is in green, the 0.2 to 2.5 is in red, the course is in blue, and then the total PM 2.5 is in black. The values with filtration are with the dotted line, and the solids are with the sham filtration. So if you look at the all the way to the left of the graph, you can see the considerable drop in the distribution for the PM 2.5. Likewise, looking at all of those other ones, you can see with the standalone filtration, we had significant decreases. Here we go for the standalone filtration on the indoor-outdoor ratios. You can see all of them are decreased, with the least decreased for the course in blue. You can see that the blue is slightly offset compared to the other ones. And here is our central system concentration distributions. Again, same color coding. You see the good drops with the green. Here you can see that we have the two blue lines. They're a little bit hidden behind the black, but they're right near each other. So we had very little drop with the central system between the true and the sham filtration with the central system for the course PM, likely because a significant amount, as I said, or actually maybe I didn't say, for the central system, we ran the system for 15 to 20 minutes a day, whether it was true or sham, and during the true period, we had a high efficiency filter, and during the sham filter, we had a very low MERV number filter, because obviously the participant would notice if their heating and ventilation system was running a lot during half the time period and not running very much the other half, so we had to do it with a sham filter and still run it. And so likely we were removing a decent amount of the course PM with the low MERV filters, because that's what the low MERV filters are most efficient at removing. And here you see the plots with the indoor-outdoor ratio, again seeing significant drops for all of the size fractions except for the course. On the PM 2.5 filter, we also did reflectance, and so we calculated indoor-outdoor reflectance measurements. And here for the true, you can see our indoor-outdoor reflectance measures, again being for PM 2.5 on the medium are quite low, 0.15 for the air cleaner, 0.2 for the central filtration, and they were a lot less than the sham ones. Okay, so objective 1, determine if we had high efficiency filtration in the indoor air levels. So far I've just sort of showed what it looked like, so that kind of hints at some of what the statistical analysis is going to find. But we did do a formal statistical analysis as well. Our outcomes were the indoor concentrations of the various size fractions, the indoor-outdoor ratios of the various size fractions, the indoor-outdoor ratios of the reflectance, and the indoor ozone concentrations. Our predictors in the model were sham versus true, and also air cleaner versus central system, and our covariates were the seasons, spring, summer, fall, and winter, so basically the model adjusts for that, it adjusts for the city, and puts in a random effect for household ID. We used a generalized linear mixed effects regression model. One of the good things about using this model is we're able to incorporate participants that had some of the data available that completed part of the study, but not all of the study. So that's what it looked like. Okay, so here are some of the results. So this is the contrast in the log geometric PM concentrations for the filtrations, whether it's true or sham, in the log normal mixed effects model. And so here, our sham versus true, we see that we had a considerable drop in the true levels versus the sham. We had similar drops for the PM 0.2 and the PM 2.5 fraction. However, over here on the PM 2.5 to 10, the course, we had a much smaller drop. If you look at 2 columns to the right of all the red circles, you will also see the p-values, and they are all statistically significant. The lines above have the pre versus sham and the pre versus true. And we see, as we expected, I did mention that the pre-intervention concentrations were higher, and we do see that because we see that the pre versus sham have positive values as well. Now let's look at the differences between the air cleaner and the sham. So in this case, what you're looking at is the contrast between the true and the sham. For the air cleaner is on the top line, and for the central system is on the bottom line. And you can see for PM.2 that you have a greater improvement with the standalone air cleaner than with the central system. You have roughly the same values for the PM 2.5. And then let's talk about how these are compared. We then looked at the differences in the reduction with the air cleaner versus the central system, and you can see that the air cleaner has that large positive improvement, and you can see that the p-value is 0.01, so it was statistically significant that the air cleaner did a better job at cleaning than the central system. Over here you can see basically all of our values are significant, but except for one, the air cleaning with the central system of the course PM. If you look at our 95th% confidence interval, it includes some negative values, which indicate that we did not have significant improvement of that size fraction with the central air cleaners. Converting these into percent reductions, you can see what basically the similar trends to what I was saying. We had significant reduction, or we had larger reductions for the smaller size fractions and smaller reductions for the course on the right. Comparing the second line and the third line, you can see that we had greater reductions for the air cleaner than the central system. So that's another way of looking at that. We did a little bit more work on understanding the comparisons with the pre-intervention. And here you can see that we had bigger improvements for the, we had differences for both the air cleaner and for the central systems for this. And the differences in the sham between the two systems were not significant, but you see that the differences in the true were significant, with the air cleaner levels getting lower than the central systems. And so here we look at the percent reductions of true versus sham for both all homes and also for the air cleaner and the central filtration homes. And you can see that we had better reductions, bigger reductions with the true for the air cleaners than the central filtration. We also did analysis for the indoor-outdoor ratio, and I just show you the percent reductions, and they follow the trends with the smaller size fractions having greater reductions and the central filtration in the middle having smaller reductions than the air cleaner, standalone air cleaner homes on the bottom line. So the take-home message is basically that having an air cleaner high-efficiency central system lowers your PM levels. The difference between the true and the sham is greater for the air cleaner than the central systems, likely because the central systems also ran in sham just with a lower efficiency filter. And the values were also higher for the pre than the sham for both the air cleaner and the central systems. Next, we looked at a variety of moderators to understand if any of these factors modified the relationship between the true and the sham. The ones that we had the strongest hypotheses for were the days with windows open for more than 2 hours, because if you increase the exchange rate of the home, your air cleaner is going to have a hard time keeping up with the particles coming into the home. The year of the home built, we anticipate that housing stock in California is generally leakier if it was built before 1977 versus after. And so again, if you've got a leakier home, it's harder for the air cleaner to keep up with the particles coming in. We think that the filtration use is the participant using it as much as we ask them to, and also the filtration fraction. So what percent of the air in the home, including the size of the home, how did that influence things? And then we also looked at some things that we think influence indoor levels in general, although had a less clear understanding of how they might change the effect of the filtration. So indoor combustion, outdoor PM, presence of gas stove, and distance to roadway. So windows. Windows basically was the question in the questionnaire was whether or not they had the window open for more than 2 hours a day. And we categorized, it was done on the symptom diary, so we had a count for the week when we were doing the air sampling. If they were open 5 or more days a week, that was approximately 27% of the homes opened them quite a bit. Sometimes open was 2 to 5, rarely open was less than 2. Half the people had rarely open during the sampling week. And because we had such big differences between air cleaner homes and central homes, we needed to do the analysis with those two separate, or else we wouldn't be able to disentangle things very well. So here is the plots or the results for the windows. And if you look at how to read these, so with the arrow, you have the reduction for air cleaner homes for homes that always had their windows open. And if you compare that to the brackets, the people that had it sometimes open and rarely open, you can see that the people that had it open sometimes or rarely had a bigger contrast between their true and sham values than the people that had their windows open all of the time. For the central home systems, you can see the same sort of trend, but there you have very little difference between the true and sham values for people with a central system that had their windows open most of the time. In fact, that was not significant difference for that subset of individuals. So now what you want to do is understand, okay, we can see that the trends are showing us that we have more cleaning if people keep their windows open, but then we want to look at whether or not this was statistically significant. I should have stated that for most of the analysis for looking at a single term, we counted p-value of 0.5 as significant, but for looking at interaction terms, we considered anything up to p-value of 0.15 significant. So these were sort of borderline significant between always and rarely having your windows open. For an air cleaner, the central system, even though we see the same great differences, because the sample size is smaller, those did not reach statistical significance. We see it was significant for both 0.2 and 2.5. Okay, next interaction term, age of homes. 40% of our homes were built before 1977. We think that there would be a greater difference in the true sham differences for the newer homes because they're tighter. We did see a very small difference in that direction for PM.2 of the air cleaner homes. PM2.5 did have a significant difference between new and old homes. So, you know, it was just at the borderline. So we saw a little bit with that we would anticipate. On the burning, we did see higher levels of indoor concentrations if we had more burning for PM 0.2, slightly higher for PM.2, but there's no differences on true versus sham by number of days burning. Given the fires, I mean burning things like your stove and cigarettes and things like that inside your home. There were no cigarettes since this was a non-smoking population, but burning other things in the home. Okay, filtration use ratio. So your filtration use ratio was 1 if you ran the filter or the central system as much as we asked you to. And here, because this is a continuous variable, when you do the comparisons, you have to set sort of a hypothetical value. You can see in all cases, the beta is larger if the use ratio is 1 versus the 0.75 for both the air cleaner and the central system. And if you look down here on the PM.2, you're sort of borderline significant at improvements for that. And at the PM2.5, you're definitely significant for the interaction terms. So this really surprised me and really showed the importance of running the intervention, because as you'll recall from the slide where I showed you how much they ran it, I didn't think we were going to see anything here because almost everybody ran it all the time. And so when you don't have a lot of variability in your predictor variable, it's very difficult to see a significant finding. But even with that little variability, we were able to tease out a significant finding for this interaction term. So it's really important as to whether or not they ran it. We looked at the reflectance. We also looked at the concentrations with distance to road and didn't see anything. But the reflectance, that indoor-outdoor reflectance ratio, we did have some slight significant events here. These are a little bit difficult to interpret. This is for the PM2.5. We had good variability with 35% of our homes less than 2 blocks from a major roadway, 29% 2 to 4, and 36% 5 or more. If you look at the differences on the first 3 lines, we are looking at the true versus sham values. Here we did the air cleaner and the central system homes together because for reflectance there was not a significant difference between the 2 groups. And you can see that you had a greater decrease for the homes less than 2 blocks and for the 5+ blocks versus that middle distance 0 to 2 blocks. So it's sort of odd because it turned out that these were they were statistically significant. The 2 to 4 versus the 5 blocks, there was a statistically significant difference, but it's kind of weird. It was the intermediary group rather than a trend that was constant in one direction. We dichotomized at less than 5 blocks and more than 5 blocks. And again, we found a statistically significant difference where homes 5 or more blocks from the road had more significant reduction in reflectance than those less than 5 blocks from the road. We think that this might not have a lot to do with the distance from the road, but more to do with differences in the housing stock of houses that are further from the road and closer to the road. Obviously, it's more desirable to live further than a road than right next to a road, and so the quality of the housing stock tends to be better for those that are farther away from major roads. They tended to be the newer homes. We think that this might be a little bit confounded. Okay, personal exposure model. We did a personal exposure model looking at time at home, outdoor school, and indoor locations. We came up with a time budget based on EPA's recommended times. We then looked at distributions for each of these and calculated the distribution of concentrations, assuming that the people had filtered or unfiltered air. We can see here is the percentile of the distribution of our personal exposure model for the filtered homes on the top and the unfiltered homes in the bottom. And we do see that we predicted lower concentrations of your personal exposure overall for your filtered home versus your unfiltered home. Okay, objective 2, looking at the high efficiency filtration and reduction in asthma-related health endpoints. Here I put this table of data completeness up just to show that people were really good about, if they were in the study, obviously we had people drop out over time, but most people conducted their visits. We had very few people miss visits. We had very few people not turn things in. The only thing where we had sort of any problem at all, if you look on the mini Packwell line at the off months, 3, 9, 15, so forth, you had slightly lower just because that was done through the mail instead of over the phone, and the kids were expected to fill it out and the parents were expected to mail it back, and they didn't do that quite as well as when we were on the phone with them or there in person. On the statistical analysis, we had our primary outcome, as you'll recall, was the number of asthma symptoms in the last 2 weeks, which was the greatest of those 3 questions. We had a list of secondary. We did the true versus the sham, and again, had the same covariates. We had the same linear model, but I don't show it here. So what was the primary health endpoint results? We looked at this with both as a Poisson and ordered multinomial. We ended up using the Poisson distribution. As you can see, just looking at the true versus the sham, we had slightly more days with asthma symptoms with the true than with the sham. But that's when we realized we needed to have the year-to-year effects, because we also found that we had significantly fewer symptoms in years 2 than year 1. And as I said, there's a number of reasons that you would anticipate kids' asthma to go down over time. They learn to better manage it, they get more mature, and as you know, a lot of times kids outgrow their asthma. And then because they were recruited into this study by having had symptoms flare up 6 months prior to the study, it might have been a regression to the mean. They don't always have symptoms, but it had flared up, and now they're going back to their normal status. So we saw that we had more symptoms in year 2 than year 1, so we added the study year variable to our primary analysis. And as you can see here, our true versus sham, the p-value is 0.4, so there were no significant results. We also did the balanced study design, where we looked at months 1 through 6 and 13 through 18, because in that case, you had true versus sham or sham versus true, and eliminated the problems with the time. Again, we did not have any significant events, but also we note that we didn't include as much data in this because you're only including a fraction of the instruments. Okay, mediators and moderators. So mediators, we considered controller medicine use, flu, and indoor PM 2.5 concentrations, and none of those were mediators. Then we looked at the moderators. We looked at air cleaner versus central, asthma severity, allergies to a furry pet with a furry pet. It always surprises me when you've got the kid with the asthma and they're allergic to furry pets, and yet they still have the furry pet. But there was enough in that category. We could look at that. The gas stove or oven, and the filtration utilization. So asthma severity and air cleaner central were the only moderators. Here's our asthma severity. We had to use our definitions because asthma severity, as it's officially defined, is based on how many symptoms and what the lung function is if the child is not taking any controller medicine. And since most of our kids were on a controller medicine, we couldn't use sort of the official severity definition. So we made our own based on the number of controller medicines they had, the number of unplanned visits they'd had in the prior years, and factors such as that. You can see that the majority of our participants had either mild or moderate asthma, whereas slightly right around 9% had severe asthma. So ideally, we would have wanted to have more severe asthmatics in the study because we would anticipate that a severe asthmatic would have more improvements in their symptoms relative to mild or moderate. But since we were recruiting through the schools, we just didn't get that. We couldn't find that many severe kids. So this is looking at the mild, the sham versus true, the primary number of symptoms for the mild, the moderate, and the severe. You can see that there was actually a slight increase with true for the moderate kids, whereas you had a slight reduction, although it didn't reach statistical significance, for the severe kids. And the differences between the moderate and the mild, the larger groups, did reach statistically significant difference in their reaction to the study. We also looked at the pre versus the sham versus the true in this regard. We did have more symptom days in the pre-period than during the study period overall. This also supports the idea that we might have had some regression to the mean with kids improving over time, or just as they got older, because we did have these greater number of symptoms for pre versus sham and pre versus true. And you can see that that was more pronounced for the moderate and the severe kids in the interaction analysis on the next line. Okay, let's look at secondary health endpoints. We had quite a few that did not have any significant findings. The use of rescue inhaler, the missed days. We didn't do missed work because a lot of people had one parent at home, so it reduced our sample size. The steroid treatment, we barely had anyone doing the steroid treatments. The mini Pacwell scores on the emotional function and the physical limitations, remember that had 3 scales. There was also an asthma severity, the mini Pacwell as the child completed. The mean exhaled nitric oxide, and the spirometry. The unplanned healthcare usage, we considered 3 things in that. The number of times they visited the hospital, or stayed overnight in the hospital, visited the emergency room, or had an unplanned clinic visit. We also looked at clinic visits on their own. We couldn't look at hospital visits or ER visits on their own because there were just so few of them. But if you look at visits to the hospital emergency department or the clinic in the last 3 months, one of the things I want to note here, I'm saying in the last 3 months, because when we did the symptoms, you'll recall, that was only asking about 2 weeks. And when we did the unplanned medical visits, that's something that's easier to remember. Like if you had to take your kid to the doctor because they were having symptoms, you're going to remember how many times you did that over 3 months. And so here we were able to get basically coverage over the entire study because we asked them this question every 3 months. So we basically knew how many times they went to the clinic the entire time they were in True and the entire time they were in sham. And so it's covering a much greater time period. And here we do see that we had less unplanned encounters with the health system in True versus sham, so that was a 19% reduction, and it was primarily driven by the severe asthmatic kids, so that's a small number of the people, but they had the greatest reduction, and you can see that by this. We then also looked at clinic visits on their own, and there you see similar with a 20% reduction overall between the True and the sham. And then on the interaction, but the milds had a significant 21% reduction, and the severe had the significant 43% reduction. On the mini Pacwell scores, the kids were asked about their asthma symptoms over the prior week. We had to reverse the scores because a good score is a 15, and so we had to switch that to being a 0. But here we go. Here is the analysis of that. This was a little bit odd because if you look at the True versus sham, we do see a nearly significant improvement with the True versus the sham. But oddly, if you look in the interaction analysis at the moderate line, you see that only the moderate has a p-value of less than 0.5. And so the moderate kids had a significant improvement in their reported symptoms. But the reason I see this as odd is because they're the group that had worse symptoms when you asked their parents. So we're not quite sure why the kids thought they were better in the True, and the parents thought they were better during sham. So we decided that that was a bit hard to interpret. Okay, the bedroom door. Going back, as you'll recall, those kids with the standalone air cleaner had 2. They had one in the main living area and one in the bedroom door. So the thought was if they shut their bedroom door at night, it was 105 CFM in their room. That's going to really clean out the particles in a child's bedroom because those are not very big, particularly if they shut their door because then you're decreasing your exchange rate with the rest of the home. And we did see that it was statistically significant that kids that, and again, this was a continual variable because we asked the kids every night whether or not the bedroom door was closed, and we were able to categorize that. But basically, we did see that if they kept their door shut, they did wake up less during the night. And so that was definitely good and shows the importance of properly utilizing the intervention. Okay, moving on to the discussion. So we nearly reached our enrollment goal of 200. We got 191. Only about 11%, actually 9% were classified as severe. Ideally, we should have had this be higher. Our population was fairly diverse, and we nearly met our completion goal of how many people completed the study as well. On the central system filtration, this did logistically add a lot of complexity to the study, primarily because of the thermostats. However, we think that without running the clean air cycle, especially in new housing, this could be a really cost-effective way to clean the air in the home, and more should be done to evaluate the better filtration in the central systems. We do think it's a little bit more problematic in the older HVAC systems simply because if the fan is very inefficient, it's slightly a more expensive way to go. The standalone cleaners were super easy to use in a study. They were easy to install. They had known electricity. They were great. We did have some problems with the VOC filters because some people had very high VOC levels in their home. Not necessarily when you think VOCs, the ones that you're thinking of is the sort of classic air toxins, but these were also cleaning out, any of the fragrances from the air cleaners, and people that sprayed a lot of those or had other things. And if it got full, then it kind of caused an unpleasant smell. So that actually accounted for some of our people that didn't have good usage because it would start to smell, and then they'd turn it off, and they wouldn't, some were good, and they'd call and be like, oh, there seems to be something funny going on, and we'd come change out their filter. But some just turned it off and didn't tell us. So Now, on the indoor air quality, the discussion points are that both standalone air cleaners and central system had a clear positive effect on indoor concentrations, and this varied by size fractions, with the smaller size fractions having a bigger improvement than the bigger size fractions. And this makes sense because the larger size fractions have greater deposition velocities, so when you add a removal process to something that has a low deposition velocity, that's going to be a bigger change than if you already have your decent deposition occurring just in general. So that it made sense that we had better improvements on the smaller size fractions, which is why, the main goal of the high efficiency filters. And the air cleaners resulted in greater reductions than the central filtration. On the interaction terms, we saw that things related to air exchange, such as the windows, had a better improved things, particularly for PM.2, and that the more we filtered the air, the better the air quality. The distance to road was a little bit inconsistent, but had some significant results. Now, we did have higher levels during the pre versus the sham, and there's many potential reasons for that. The outdoor levels were slightly higher during the pre-intervention than during the study period. There could have been greater sources that could have been part of it. We do know that some particles were removed with the sham filtration. So in the central system, we know that we had a low MERV filter going in there, but also, even on the sham, we bypassed the filter, but there was some deposition. I think it must have just been some sort of electrostatic. I mean, this looks bad, but when you compare it to the true, I mean, the filters were disgusting when they came back. They collected a lot of particles. But we were definitely, and this is one of the dirtiest ones. Normally it was just a slight tinge. Most of the shams were so light we could put them in as call it a new sham when we went back to the home, but some of them in the dirtier homes were noticeably unclean when they came back. One of the other thoughts that we had is as you increase the air velocity in a home, that increases the particle deposition. And so by running the air cleaner, you're running 300 CFM blowing out into the room. So you are increasing the deposition velocity even in the sham, just because of the increased air velocity. Likewise with the central, we were running it more, so we were increasing the velocity, and so that could have resulted in an increased deposition velocity. That's been recorded. There could have been other behavioral changes that we were unaware of. Okay, on the asthma symptoms, we didn't see, unfortunately, reduction in the primary outcome. And what we think is we might have had regression to the mean. As I've said before, you had to have symptoms to get in. Maybe it was just a flare-up, and now you're going back to a lower thing. Maybe you learn how to manage your child's asthma better over time. We spent a lot of time really digging through the controller medicine use, and it did seem that a lot of people were playing around with that because people's controller medicine use would really change from period to period. Kids are places other than their home, so maybe the fact that they were only having a reduction in their home meant that they were exposed to triggers outside of their home. Maybe there were other external factors, such as more colds or flus going around in one period versus the other. Maybe we just didn't have a great enough reduction in the concentrations, especially given that they were other places. And the size fraction we had the least impact on was the larger particles, because those were lower to begin with, and many of that's sort of the ones that would be associated with allergies. So we don't know for sure. The unplanned medical results were reduced more so by the severe asthmatics, and that's actually really important because the severe asthmatics are the ones that are going more, and so that would be driving the medical costs related to asthma, because if you go a lot, it costs more money. We think that this endpoint was more robust because, as I said, it was the full study period because we did it over those 3-month blocks instead of over 2-month blocks. We thought that the improvement in sleep when you kept your door shut showed the importance of utilizing the intervention to its maximum. And there have been other studies that have only looked at bedroom air filtration. And so if you were contemplating, maybe what's the way what's a way you could do this less expensively? Because obviously you're having to pay for electricity to clean air. Maybe an additional study should be done only installing air cleaners in the kids' bedroom, because you might still get some of the improvements at a lower electricity cost. We didn't have confidence in the mini Pacwell symptoms, but they were significant. So take-home messages, the participants had lower symptoms with time, and thus there was no improvement between true and sham. A little bit was seen with severity, and the main result in the right direction was the medical events were significant, unplanned medical events were significantly improved in true. And I'd like to thank the ARB for the funding for this study. This is the statement that they gave me to put in anything I present. And we wanted to thank all of our participants and field staff. Our field staff worked tirelessly down doing these visits. This was a lot of work to get all of this completed, because they were, generally doing 2 visits a day. They were quite lengthy, setting stuff up, taking stuff down, so they really worked hard. So that concludes my talk. I would be happy to take any of your questions.
Thank you very much, Dr. Bennett. It was a very nice talk. So yeah, we can open this up to questions. Anyone online attending the webcast, they can submit their questions via email, but I'll start with folks in the room. Does anyone have a question?
Hi, thank you for the research and the presentation. I'm Kevin Messner. I'm with the Association of Home Appliance Manufacturers. So we represent air cleaner side of it. So that's why we're interested. Had a couple questions. One, curious on the 0.2, 2.5, and PM10 levels, and which one, if any, did you find? I didn't quite understand why the PM10 level didn't go down as much.
The reason the PM10 level doesn't go down as much is because the PM10 includes the sort of particles between PM2.5 and PM10, which are the coarse particles. So the coarse particles have the greatest deposition velocities. Yeah. And so without the air filter, and especially with the increased air velocity in the room, they're already falling out. So they're already sort of decreasing. So if you think about, you have a source of particles coming from the outdoors and from the indoors, and then your concentration is going to be dependent on how many you can remove. So they have the biggest removal rates before you install the air cleaner. So adding that drop for the air cleaner doesn't do as much, because you already have a lot of them being removed naturally. So the PM2.5 and the PM0.2, those ones stick around in the indoor environment. There's really no removal process without the air cleaner. So when you add the air cleaner, you really can see a really significant drop. So that's why you see the bigger drops with the 0.2 and the 2.5. And that's important because without the air cleaner, they don't have any way to be removed. And so it just has to do with the natural...
Yep, that makes
and
sense.
Also, partly too, the coarse particles are going to be sort of more affected by the sham, because all the results we're looking at the true versus the sham. And so those larger coarse ones, for example, in the central system, just the cheap filters that you buy for 99 cents or whatever, those are good at removing is coarse particles. So now if I'm running the HVAC system, the central system, 15 to 20 minutes a day, I'm already sucking those out. And so I put a better filter in, I'm removing slightly more, but since I was already removing them, I don't see that difference. Whereas where you see the big improvements with the improved filter is on those fine particles. Yeah. And the fine particles are the ones that are generally thought to be more important from a health standpoint.
That was my next question. Yeah. Whether the 0.2 or the 2.5 is
most
one.
Most of the health studies are on PM2.5 because that's the easiest to do your health studies with. Yep. And so that's where we see the most, we definitely see better, more significant relationship between health and PM2.5 than PM10. The ultrafines are very difficult to study in large epidemiology studies. And so scientists think from sort of toxicological experiments and so forth that the PM0.2 is probably fairly important, but it's more difficult there's just been less work done on that, but we think that they're just as important or perhaps more important.
Okay, great, thanks. Just got one other question, maybe two. So I was a little curious on two things, or maybe the central, so the air cleaner was more effective than central.
Yes.
That's good for our products, air cleaners, so I'd like to hear that. But just curious why you think that? Is that because it's, well, why did you think that? You mentioned a little bit, but maybe you could go into that a little more detail.
It's hard, partly because we're looking at the contrast between the true and the sham. Partly, we also just had smaller numbers of the central ones. I'm suddenly getting worn out from this. What did I say here?
One possibility is, I mean, for air cleaners, the filters, the filtration system can be, you could have multi-layered filtration system where if you have a filter and a central, it's, you're setting in the air filter, maybe it's a whatever level it is, but there's potentially, I didn't know if there was a different level of
No, they're both IQ air filters with the same efficiency.
They were the same.
I mean, the other thing that I didn't mention and I didn't put in the report because I don't really have a good way of quantifying it is also we generally did our measurement in the main living area where one of the air cleaners was, and the HVAC is running the same volume through the whole house versus the air cleaners, which might be doing more volume in one room versus the other.
Yes. Yeah.
So...
Yeah. Start and stop with the HVAC system.
That too.
There's a start and stop. The air cleaners are running constantly all day.
That's what I was wanting to see. That was my other. The air cleaners were running 24/7.
They ran 24/7 theoretically, but since their total was ideally 475 CFM and a typical central system runs at around 2,000 CFM. It wouldn't have been comparable to run the central for 24/7 because we would have filtered much more air. But it's, as Jeff points out, those bursts where it's running and then not running, running and then not running.
So last, I was curious, there's no impact on asthma. I just found that a very...
Yeah, I think that had a lot to do with the study design because we wanted to give everybody some true intervention in the first year of the study, but I think since there was a lot of improvement of people's asthma symptoms over time, the fact that we didn't have a balanced study design made it really difficult to tease out any improvements in symptoms. But we did see the slight improvement in decreased unplanned medical events.
So your research doesn't lead to the conclusion that air cleaners don't help if you have asthma, or doesn't make a difference if you have asthma?
No, we would never say, when you have a negative finding, you never say it doesn't matter. You just say, we weren't able to show anything. Right. So, especially since we had the problem with the time problem. We're not saying, it doesn't do anything. We're just saying our study wasn't properly designed to find a difference.
Thank you. Thank you for doing this research.
Any other questions?
This is truly a fantastic study and covered a lot of ground. But I was just curious, can you explain the reflectance measurements?
Yes.
And what they mean and how they were done?
Yes. Basically, the PM 2.5 was collected on a Teflon filter. And then you basically shine a light on the filter and see how much reflects off. And that has been found to correlate with the amount of black carbon in the particulate matter that you collected, especially then you correct for how much mass there was. And so the black carbon is primarily results from PM coming from diesel vehicles. And so the reason that you do the reflectance is your total particles in your house are those of outdoor origin and those generated inside, where by doing the reflectance, you're really isolating the study to only look at the effect on outdoor particles.
Okay, any other questions from the room?
Yep, thanks, Debbie. This was great. You mentioned study design, and what would you recommend? How would you improve that if we were to do another asthma study?
I think if you were to do another asthma study, there's two things I would consider. I would consider doing an asthma study only using the standalone air cleaners. I would do a balanced study design, so you were a year true, a year sham, a year sham, a year true, so that you wouldn't compound things with your time events. That would be one thing I would consider. Another thing I would consider would be to just put it in the kid's bedroom and see what you get there, just because that would be a lower cost way of cleaning the air. And finally, the other thing that I would consider would be to do a larger study, but where you only installed a high-efficiency filter without a thermostat that had a clean air cycle, particularly in areas where you had newer homes, so that you were only taking advantage of filtration when you were cooling or heating, but this would add virtually no cost to, no electrical cost. And so you could do a larger study just doing the questionnaires in a very cost-effective way, only considering the filtration switch only when it naturally ran and not do the clean air cycle. Because the thing that was problematic and difficult with the clean air cycle is I think that a clean air cycle would work great if you're manufacturing new homes and you have an efficient fan and you have a 5-wire system where you can supply power and get you have your choice of smart thermostats. But I think in existing housing stock, it makes more sense if you want to do something through the central system to just let it run when they heat and cool.
Okay. Are there any other questions? All right. And I don't think we have any. Hold on a second here. It looks like we do have one question online. Okay, this question comes from James Nakashima in Oiha. He says, compliments to your staff, complicated study. I agree. The question, he says, so background air quality varied quite a bit from house to house. Do you have a sense as to whether or not air quality varied quite a bit from house to house?
The outdoor, I'm not sure if he's asking about what it was. Hang on, let me get to my summary statistics, which are not going very quickly because I added all this animation. Okay, so if you look at our pre-intervention, let's focus on the PM.2 to 2.5 line. So our 10th percentile to our 75th percentile was 3.5 to 10. So it was fairly significant variation across the homes, I would say. But I don't think that this is out of the ordinary. I think that this is a fairly typical range for your distribution. Your standard deviation was slightly lower than your mean, and so I think this is a fairly typical distribution of the range of particulate matter over different homes.
Okay, and then a follow-up. You wanted to know, how did you measure medication use? You said, was that just self-reported data?
Yeah, medication use, we did two things. One was we asked about use of rescue inhaler as an outcome, and the other was we had them report their controller medicine. We spent a lot of time trying to figure this out because controller medicine is actually way more complicated than I could have ever imagined, because you have some products that have 2 medications in them and some products that are only a single medication. And so basically, I think we said if you took it 4 out of 7 days, that counted as taking it. And then if you took it 2 to 4 days or something like that, we gave it sort of a half score. And then we summed the number of medications that they took. So some of our kids were on 3 controller medicines, taking them regularly, so they would get a score of 3. And so basically we were summing the number of controller medicines, and it was self-report. When we were there at the 6 when we were there in person, the parents would often bring the medicine box out and be like, yeah, they're taking this time, and so they would show us. So it is the self-report from the parents, but we feel like they were fairly honest about whether or not they really took it or not.
Okay, thank you. And we have a comment from our long-lost manager, Peggy Jenkins. It's nice to hear from her. I hope she's doing well, recovering. She just said she wanted to thank Dr. Bennett and her team, especially Rebecca Moran, for their dedicated work on this important and challenging study. It's provided much new information regarding high-efficiency filtration as both a PM reduction method as well as an additional tool for addressing asthma. We truly appreciated all of Dr. Bennett's efforts. And Debbie, I hope you'll continue your analysis and research in this area. And I certainly would want to echo that. This was a tremendous effort, a huge project, and they really did a fantastic job.
Great, thank you.
With that, are there any last comments in the room? Okay, I think that concludes the seminar for the day. Thank you very much for attending. And thank you again, Dr. Bennett.
Yes, it was a lot of work, but yeah.
Through those slides.